Thanks, Dr. Chitra. Like, as they say, Dust spoke the vitreoretinal surgeon, so probably the cataract surgeon will talk. So dust vitrectomy itself in intermediate uveitis. The question is, I probably got the clarity a little late, I thought, but then I rechecked the question. It was like, does vitrectomy itself in intermediate uveitis have a therapeutic role? So the answer is no. In any case, I don't like any vitrectomy in any patient because I'm a cataract surgeon. So I would like to have vitreous in its cavity as such safe. So if you find any of this, you find a spillover anterior uveitis or vitreous cells or any of these, you would start thinking about intermediate uveitis. So where is the inflammation in intermediate uveitis? The inflammation is actually in the middle, in the pars plana region. Okay, so somewhere in the middle, whenever I think of middle things, I keep thinking about this Thracian group. Something like us, probably like we uveitis specialists are neither anterior segment people or posterior segment people, or we are both. I don't know. We'll have the debate for another day. But remember this condition. It is an inflammation of the vitreous and pars plana, and we are thinking of treatment of a pars plana vitrectomy. And it's really scary. The last time I heard about this was wound debridement. This looks like wound scratching. I heard something like that was as an intern for a carbuncle. Even then, I was told that you treat and control the diabetes. That's the primary treatment. I was taught to treat intermediate uveitis like this. If you have vitreous cells and a patient doesn't complain too much, you can probably watch or give them some topicals. If there is a spillover anterior uveitis, treat them with topical steroids or NSAIDs. If you have vision drop along with posterior segment manifestations or CME, then you image and investigate. So based on that, you treat them with periocular or systemic steroids or immunomodulators, but definitely not vitrectomy. I'm thoroughly confused. We just had an discussion with experts telling whether to treat or not intermediate uveitis, and we are talking about straight away vitrectomy in a therapeutic role. So, see, the initial description of vitrectomy was by my teacher's teacher. I'm trying to gain brownie points from the panelist, Dr. JB. So, this was initially described by Charles Keepens. The modified Kaplan's approach came in later, which said that the posterior subcutaneous injection was the first choice. Now, probably other periocular or local intravitreal injections, oral steroids, immunomodulators, or biologicals, and then finally laser vitrectomy. I think somebody mistook this four-step ladder approach because vitrectomy was on top doesn't mean vitrectomy is a treatment option. So if this is what people say is old or conventional teaching, then what does the current literature say? So I went through the literature also and found that most of these studies remain lack of application of standardized reporting outcomes, and so you can't rely upon it. You need to take them with a pinch of salt. And some of the studies show that pan uveitis has better outcomes than intermediate uveitis. There was a large study of 6 children which promoted pars plana vitrectomy in intermediate uveitis. And then I saw this TB uveitis study which showed that adjunctive pars plana vitrectomy case control study had facilitating faster resolution. Then I realized this is Basu et al. So then I just moved on to the next one. So we had this randomized pilot study many years back, which again didn't conclude conclusively that it is better, but they just said that you need to have a prospective randomized multi-centered clinical trial. This was years ago when I was a fellow or probably after that. So at least if it's pus in the body, they say dictum pus anywhere in the body, you need to drain. But this is not necessarily always even in the eye. If it is end of yes. But remember, hypopain uveitis in Behçet's or HLA-B27, you treat them medically. And come on, in intermediate uveitis, it's not even pus. Remember, what causes intermediate uveitis? It is because of autoimmune diseases, infectious, masquerades, and others. We saw Rima and Mudit talking about syphilis and lymphoma. So can vitrectomy solve all these systemic issues? It's just a temporary clearing effect of the debris. You need to treat the cause. And Soumya actually gave me enough tips against vitrectomy also, considering the risks of early cataracts in young patients. I really got to know that glaucoma is one of the major complications post-vitrectomy surgery, not hypotony. Risk of infection is there, and there is a big list of things. But I'm not sure how we identify the pro-inflammatory cytokines while you're doing vitrectomy and remove them one by one. So anyway, we really have a big, very nicely written review article which says that ultimately it is important to achieve an optimal control of inflammation for best results before planning vitrectomy. So it all says that risk-benefit ratio for vitrectomy is very high despite MIBS in an actively uveitic eye. See, remember that vitritis or vitreous debris is not the main cause of vision loss. The predominant cause of vision loss is in intermediate uveitis is cystoid macular edema. So, vitrectomy clears actually the vitreous exudates. If at all it has a role, then probably there is a vitreomacular traction in CME. So, if you're still itching to do something in the eye, then probably you can think of giving subtenons, intravitreal or Ozurdex or fluocinolone. So, they say if a sink gets filled up, then it's important that you plug the hole and stop the flow. Like there's no point just clearing the sink alone, and that's not the way to go about it. We've always been taught from our medical days that if you have a pitting pedal edema, treat the cause, cardiac failure. You have a 25 gauge, 26 gauge, or a 27 gauge needle or a technique, draining is not the treatment of choice. So the preferred treatment algorithm may be that intermediate uveitis, if vision is normal or minimal signs, probably you can watch. And if there is significant inflammation, if it's unilateral, local therapy probably. If it's bilateral and associated with systemic condition, then treat systemically. Surgery comes into play when vitreoretinal complications or if there is cataract. Thank you.
Thank you very much, Dr. Sudharshan and Dr. Basu. That was a lot of thoughts on that interesting topic. My question is that if you're going to be doing, question is to Dr. Ratnam. If you're going to be doing a pars plana vitrectomy, and it's all about good base shaving, does that mean that you would knock off a clear lens? Does that mean that you would do a pars plana vitrectomy with an IOL surgery too? Dr. Ratnam?
Yeah.
Sudharshan, can you stop sharing?
Yes. Can you kindly repeat your question because the phone was ringing?
Yeah, phone was ringing. Sorry. No, I just wanted to ask that if you're going to do a pars plana vitrectomy, does it mean that even if there's a clear lens, you would remove the cataract?
If it is a clear lens, no, I won't even touch. But if it is cataract, probably we will do both pars plana lensectomy as well as vitrectomy. And vitrectomy, as rightly mentioned by both the speakers, when we have more problem in the vitreous is opaque, or there is a traction, or there is a hemorrhage. So, and very chronic intermediate uveitis, not clearing with anything, opaque vitreous. All these things we do vitrectomy. But I want to ask Dr. Basu, with this vast experience, after vitrectomy, is there any case all these inflammatory cells come again into the vitreous or not, come again into the posterior segment? Because after all, they come from the blood vessels. If the primary cause is not treated, has he seen repeated vitreous inflammation even after vitrectomy? In that case, in which entity he has seen more? Because in lymphoma, even when we do a vitrectomy, after some time, lymphoma cells come back again.
Yeah. So thank you for the question. Yes, treatment of the primary cause is absolutely mandatory. So this I didn't highlight in my discussion, but suppose it is sarcoid or TB, which are the common causes of intermediate uveitis, which can be picked up. In other, I mean, even your study, intermediate uveitis is probably the one where the cause is least often found. But suppose we are able to pull out a cause for the inflammation, then treatment of the primary cause is essential. And suppose it's sarcoid, you definitely want to treat it with immunosuppressive agents apart from corticosteroids. So that is mandatory. So this can only have an adjunctive role, and I think both me and Sudharshan agree on that part.
Yeah, actually the term adjunctive, not an alternative, was actually given, which I put in my slide, was told by Basu. So that was like collaborative slide actually, the last one.
I have a quick question to Virendra sir. Sir, of course, I do believe with Basu sir that even I would prefer to do a vitrectomy, and the MIVS, now the surgeries, as what Sudharshan sir said about the tears, the RDs and all, with the advent of the 25 and the 27 gauge, I think those are all have definitely minimized and come down. But my question is, in case there is a recurrence, so of course the treatment of choice would be giving the PST, or what's the role of suprachoroidal kind of steroid injections, especially in case of Aios? And also in case if you have any, you need to do a methotrexate or any biologicals where we consider 400 micrograms in 0.1 ml, And what would be your dosage in the vitrectomized eyes? How would it differ?
The management, the way we should understand for intermediate uveitis, or for that matter, any uveitis, is the treatment, the surgical intervention, whether it's cataract surgery or whether we're doing vitrectomy, that's not a curative surgery. It's only an adjunct, which may help you in making the diagnosis or transiently improving the optical clarity. But with vitrectomy, there is another advantage that once you clear off the vitreous gel, then the posterior cavity is filled with the aqueous humor or the more circulating fluid. So when the inflammation happens, the circulation of the cells, clearing of the cells is much faster as compared to the vitreous. So all other medication also which you will do, they will reach better and they will also get cleared from the eye, from the posterior segment much faster. So I would think of doing vitrectomy in selected cases where there is a disease which is localized and it does not have any systemic component, and it the treatment of uveitis, then you have to follow the same principles, where if it is focal localized, use regional treatment. If it is associated systemic disease, think of systemic anti-inflammatory agents. Recurrence and all you will treat as like any other uveitis. Suprachoidal steroids, yes, of course, you can use if it's localized, and if it's localized to only one eye. The doses that I'm not very familiar. And now the vitrectomy is also not only think of that you have a very small gauge, you have endoscopic VR system. And once you go in the vitreous, you have access to the cyclitic ciliary body also. You can think of visualizing your ciliary body if there are any membranes, especially if there is intermediate uveitis associated with hypotony, which happens like JIA associated uveitis.
Thank you, sir. Avinash, sir. Yeah, sure.
You need to understand that the intermediate uveitis is not a localized disease, and it comes from that inside, even if it's idiopathic. So we need to look for that systemic treatment for that cases, and many of the times, if it is localized, you can give posterior subtenon or the intravitreal Aududex. But ultimately, you need to look long term. You need to give some kind of an oral treatment, or a systemic treatment may be required. I've seen many patients that has been treated earlier has come back with the inflammation. Another thing is that we want to tell you that intravitreal methotrexate is also a good option for treating the intermediate uveitis, which can be of use. 400 microgram you can give. So we have given few cases of intravitreal methotrexate.
So that's what my question, sir. What will be your dosage in a vitrectomized eye? Because it's in a non-vitrectomized eye where they have calculated it to be 400 microgram in 0.1 ml.
So I have not given any vitrectomized eye.
And can I have one question?
Yes, Sudharshan, sir, wants to say.
Yeah, Sudharshan, proceed.
Yeah, no, I just have a doubt with thing. Sir was telling about like not a local disease. I mean, I was just interested in Basu. He was telling about pro-inflammatory cytokines being removed out of it, and then like, is that an option of targeted therapy for that? And we have seen many patients where they always come as only one eye. It for a long time, it's always unilateral and recurring in that eye. Does it mean that it's a local disease?
Probably. And answering your question, I too have a similar question. People say that toxicillimab is very good for macular edema. Any of the seniors have experience of using toxicillimab in macular edema of intermediate uveitis?
No, I have not used it.
No, madam.
Probably we have to try, because repeatedly rheumatologist Ramanan says that it works wonderfully. So we have to see.
Dr. Kalpana, you want to add?
I have few cases where we've used tocilizumab. Some of them it works, some of them it doesn't work.
Do you give systemic toxicillimab?
Yeah, systemic tocilizumab, because the subcutaneous one is very expensive.
How much you use?
The first case which we published in long back, we gave for 2 years. And that time we used the Stills dosage therapy, which was 10 milligrams, 10 milligrams, per kg. But I think now when I look, because that time we didn't have data, and now when I review the literature, especially the trials which have been done, it is 4 to 8 milligrams per month. I feel that's not enough, because the ones which we did with 10 milligrams did much better. They did very well. But the problem is we had neutropenia because of the tocilizumab, especially when we gave them for a long time. So initially we gave them, I think, once in 3 weeks, 2 weeks, and then increased it to once in 3 weeks and then once a month. If you stop it, it comes back. So you'll have to give them for at least about 18 months. At least the case which I have given is for 18 months. And now I've been able to keep him only on azacitidine. So I've been seeing him for the last 4 years now. He's doing well, but he still has peripheral vascular leakage, but still that's okay as long as he doesn't have any CME. But I'll be showing in my talk where I've burned my fingers with tocilizumab also.
Dr. Malika, you want to add something very briefly before we go on to our
Yeah, I
next?
just wanted to say that there was a question about vitrectomized eyes and dose of. So I don't think it matters because there is no study which has shown that the dose matters, and in anti-VEGF injections, etc. also we do not alter the dose in vitrectomized eyes. So I think we can go ahead with the regular dose.
But it gets absorbed soon. If there is no VTS, any medicine will get absorbed soon.
Yeah, madam, that's true theoretically.
Might be a little faster is what.
That is true theoretically, but again, that has not been shown actually in reality by any study. So we can, and even we don't see that happening when we give anti-VEGFs post-vitrectomized for AMD or DME. We do not see that we are injecting more frequently because they are vitrectomized.
So we have been using methotrexate in case of intraocular lymphoma post-vitreous biopsy in vitrectomized eyes, and they do well and they tolerate well, and we don't reduce the dose.